Pyogenic liver abscess, PLA. A pyogenic liver abscess, PLA, is a localized collection of pus in the liver, usually caused by bacterial infection. Early diagnosis and treatment are essential to prevent complications such as rupture, sepsis, or death. Below are the detailed investigations and treatment strategies. Investigations. 1. Clinical evaluation. History. Symptoms include fever, chills, right upper quadrant pain, nausea, vomiting, anorexia, and weight loss. Patients may have a history of diabetes, biliary disease, or recent abdominal infection. Physical examination. Findings may include hepatomegaly, tenderness in the right upper quadrant, or jaundice in severe cases. 2. Laboratory tests. Complete blood count, leukocytosis with neutrophilia, liver function tests, LFTs, elevated alkaline phosphatase, ALP, mildly elevated bilirubin and aminotransferases, AST-ALT, positive in 50 to 70% of cases, identifying causative bacteria, e.g. Klebsiella pneumoniae, Escherichia coli. Serological tests to exclude parasitic infections like amoebic liver abscess. C-reactive protein, erythrocyte sedimentation rate, ESR, markedly elevated. Hack 3. Imaging studies. Ultrasound, US, initial imaging modality, identifies hypoechoic or complex cystic lesions. Computed tomography, CT, scan, provides better anatomic details and helps guide drainage. Shows multiloculated lesions, gas within the abscess, or satellite lesions. Magnetic resonance imaging, MRI, used when further characterization of the lesion is required. Chest X-ray may show elevated diaphragm, pleural effusion, or basal lung atelectasis. 4. Microbiological diagnosis. Aspiration of abscess, percutaneous aspiration for gram staining culture, and sensitivity to identify causative organisms. Stool tests to rule out Entamoeba histolytica in cases where amoebic abscess is suspected. 5. Additional investigations. Endoscopic retrograde cholangiopancreatography, ERCP, for biliary source identification. Colonoscopy, if a colorectal source is suspected, particularly in Klebsiella infections. Treatment. 1. General measures, hospitalization for monitoring and supportive care. Fluid resuscitation to maintain hemodynamic stability. Nutritional support to enhance recovery. Hammer 2. Antibiotic therapy, empirical antibiotics, coverage for gram-negative, gram-positive, and anaerobic organisms. Examples: third-generation cephalosporin, e.g. ceftriaxone plus metronidazole, piperacillin tazobactam or carbapenems for broader coverage. Definitive therapy, adjusted based on culture and sensitivity results. Duration, typically 4 to 6 weeks, starting with intravenous antibiotics followed by oral therapy. Interventional procedures. Percutaneous needle aspiration, indicated for solitary accessible abscesses. Percutaneous catheter drainage, PCD, preferred for larger abscesses, 5 centimeters, or multiloculated abscesses, guided by ultrasound or CT. Surgical drainage, reserved for failed percutaneous interventions. Multiple abscesses not amenable to PCD. Ruptured abscess with peritonitis. 4. Addressing the underlying cause. Biliary disease. Treat underlying cholangitis, gallstones, or malignancy with ERCP or surgery. Colorectal pathology. Treat infections or malignancies causing portal bacteremia. Immunosuppression. Optimize diabetes or immunosuppressive therapy. 5. Monitoring and follow-up. Clinical response. Resolution of fever and improvement in symptoms within 48 to 72 hours. Imaging. Repeat ultrasound or CT after 7 to 10 days to monitor abscess resolution. Laboratory monitoring. Serial LFTs, CRP, and CBC to ensure resolution of infection. Complications. Rupture into peritoneal, pleural, or pericardial cavities. Sepsis and multi-organ failure. Chronic liver abscess or recurrence. Prompt recognition and multidisciplinary management of PLA are crucial for reducing morbidity and mortality.